So Dan, I'll ask you the right way around. Do you have a case study or something that you would like to bring to the fore, which has maybe come to the fore for you clinically now and in the past?
Around COVID, or just something that's going along?
Take a pick, whatever floats your boat.
So maybe a question around things that we're talking about bracing. I've seen a few of the young lady multidirectional instabilities with just about, heart sink cases. And I'd want to know if there's any good evidence for bracing in those youngsters who have this terrible condition. Because these two people I'm particularly thinking about were NHS patients, and they got not much help from the usual therapy group. And these are not people that need surgery, and they had a terrible time. The only good thing about them is as they get older, they get stiffer and it gets less bad. But do you have any experience with taking young multidirectional muscle patterning youngsters and helping them with braces? Rosa?
Well, I suppose it depends. Are you talking sort of pre-adult?
Yeah, between 14 and 18.
Yeah, I think with those patients, availability to Lycra and application of Lycra can be very variable across the country. So for proper application of it, you really need to have done sort of certified training, or you can't measure, you can't prescribe. And the route at which it's supplied is also a little bit fuzzy between whether it's supplied via physio or via orthotics. And sometimes I think finding out the answer to that can sometimes be half the battle. So within that patient group, I think you really need to go down sort of a custom measurement route. It needs to be custom made Lycra, because everything else is it's not going to fit. It's not going to be snug enough to the body to have the sort of directional control and improved proprioception that we need from it. The problem with Lycra, to get the best benefit of it, they do need to be fairly high. And obviously young girls, from a cosmetic point of view, may not want to wear something that is sort of up to neck level. If you cut away a V to make it more discreet underneath clothing and things like that, obviously it's a lot more discreet, but you take away a lot of the control that the actual device can give. And I think it's working out sort of the level of importance of using that in combination with physio and patient acceptance. If a patient doesn't matter, I wear t-shirts all the time, I'd rather the support, I think there definitely is like a role for it, a place for it. But I think you need to make sure that they know what it's going to look like, and they know sort of the cosmetic sort of things that come sort of hand in hand with that. I think Rish should put his hand up. What are you going to say?
Yeah, I'll definitely add to that. I think, we all tend to look at braces as a sort of, in a way that it's not going to be supportive, especially as physios. We used to scoff anyway, back in the day about braces and stuff. And I think I work with a lot of people, a lot of teens. I myself went through multidirectional instability, dislocations repeated. Rupen was almost about to operate on me, and I rehabbed my way out of his office. And But a couple of things here is working very closely with the pain specialist. I do believe that there is a big role that they play. We certainly have one in-house, but also there's someone who's watching this who'd agree with me. There are people like Andrew Jaggi, Joe Gibson. These guys are like sort of the specialists, and they run centers for traumatic or even multidirectional dislocations, and especially in young teens. And what they notice is it's a lot about the patient story. It's a lot about the therapists sometimes in the NHS not having enough time to discuss things such as, how is home life? Tell me about this first incident. We've had people who break down in clinic because we've asked them the real reason what's happened and the real reason why they're so associated to pain. Staying to the same answer as Rosa as well, I think there's that collaborative approach, but I think working with people like you, Dan, I think is very crucial, because there needs to be that realistic approach to how we're going to sort of work with this individual. And sadly, it's like Dave mentioned that physios give out pieces of paper. Unfortunately, that's the physios at fault here, because they weren't good enough to sort of explain to the person why it's important to do the rehab. And I wouldn't say it's the patient's fault. I think it's the physio's communication that needs to work on. And I'm very strongly sort of working with physios to improve that, because that's the one tool that we have in this COVID environment is communication, and we need to really exercise it to the best of our ability.
I think, Risha, I think you're absolutely spot on there in terms of getting that patient history. So the last one I saw, the multidirectional instability, was a young girl. She was coming up to 18, and she'd had sort of this episodes of multidirectional instability, since a teenager, and then had rehab, and she was fine. And then it all started again. And it was quite odd, and it was only like when you go into the history, and it was the stress of the exams that she was about to do, and I think there was a lot of pressure on her to achieve well in order to get to the university place that she wanted to get to, and as a result, she started sort of redeveloping these sort of multidirectional instability. And what she needed wasn't a surgeon; she needed that psychological support to get through that exam, and I think that was her way of sort of detensioning or reducing her stress levels, and it was all to do with that, as to how everything restarted again.
Yeah. I've seen chronic pain symptoms, similar scenarios to that as well.